Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare and moderator for today's program. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Scott Goodspeed is Principal and Vice President of iVantage Health Analytics. Scott Goodspeed has been President and CEO of 4 hospitals in 3 states. He has deep industry experience and a national reputation in governance. He is a nationally recognized speaker who has authored and delivered over 100 presentations to various professional associations and healthcare organizations on topics such as strategic planning, health industry trends, 21st century governance, and the balanced scorecard. Scott's most recent book is titled Community Stewardship, Applying the 5 Principles of Contemporary Governance, published by American Hospital Publishing. He has recently written 2 articles on the balanced scorecard and is finishing a book with the working title Accelerating Performance, Research and Case Studies from the Top 200 Hospitals in the United States. Our next presenter is LeeAnne Denney. She is Executive Vice President at iVantage Health Analytics. Formerly CEO of Health Info Technics, LeeAnne had primary responsibility for directing the strategic growth of the company. LeeAnne has more than 25 years with major healthcare corporations developing a specialty in strategic planning and business development. Her strong analytical skills and unique understanding of how information can build strategies provide key insights to clients. These strengths will help LeeAnne as it integrates and strengthens its core products while introducing new products to meet market demands created by the new healthcare. Her leadership and industry knowledge catapulted Health Info Technics into one of the premier providers of planning information in the healthcare industry, and she plans to carry that expertise and energy to ensure iVantage reaches its potential in the market. It is now my pleasure to turn the floor over to Scott to begin today's presentation.
Welcome. The title of the presentation today is 7 Strategies to Compete Using Analytics, and let me just tell you a little bit about iVantage Health Analytics. We're a leading provider of information products, and we integrate diverse data with a state-of-the-art delivery platform which enables hospitals and systems to pinpoint vital internal performance and external growth opportunities, and today we work with over 800 hospitals. We have 4 learning objectives. We're going to talk about the 7 strategies to compete and how organizations can make better decisions and extract the maximum value from those decisions. We'll identify the analytics needed to move from volume to value and begin to talk about how you can change the delivery system. We'll talk about understanding the tools and analytics that are needed to achieve significant growth strategies and also improve clinical effectiveness. And we'll also talk about how you can use analytics to create physician partnerships to manage the cost of off quality, become adept at population-based planning, and also be successful in the competitive merger and acquisition market. And this is all in the context of a dramatic increase in healthcare spending. Federal government spending is up 23%, state government spending is up 26%, and individual consumer spending for healthcare is up 19%. We also know that there are 10,000 new Medicare enrollees per day, and the Obama budget equals the Ryan budget, and we can anticipate in January 2013 with Medicare spending, we'll see a 2% reduction in spending, more likely a 4% reduction in spending. Jeff Rose is a physician who's the VP of Clinical Excellence with Ascension Health, and he said recently that we've got AHRQ, we've got HCAHPS, and we've got the Joint Commission and meaningful use, but the most important thing that he said is getting all of this data together, consistent and valid as well as timely, is a very big deal. And we're going to talk about, in fact, how you can organize the data. So let me briefly walk through the 7 strategies that we suggest you use competing using analytics, and then I'll talk about each of those in a little more detail. The first strategy is to understand the new healthcare reality, but also to understand the performance drivers. Number 2 is understand your data and how it all fits together, and we'll talk about an approach. Number 3 is understand your performance compared to others, and we suggest that you do that at a national, a regional, state, and local levels. Number 4 is to identify ways to improve and look at internal opportunities, and we're really talking about the value equation as it relates to cost and quality. The 5th strategy is to identify ways to improve as it relates to the marketplace and understanding the market dynamics, including population-based planning. Number 6 is to understand the relationship between internal performance and the market dynamics, and we'll actually demo that capability using some GIS mapping. And then I was at a very large system in New York State about 2 weeks ago and made a presentation to a board of trustees, and the system vice chair basically said, this is all good, this is interesting, but how do we know our culture can sustain this kind of use of analytics and change? And I'm going to talk about the 3 kind of cultural styles we find in healthcare organizations, and there's one style in particular that enables competing using analytics. So the first strategy is to understand the new healthcare, and there are 4 components here. First, we all understand that we need to change the care delivery model, and we all need to be adept at population-based planning. We also need to move from volume to value. So the question is, how do we effectively manage the cost of our quality using evidence-based medicine? We've got to achieve physician partnerships, so we've got to begin to think about linked incentives. At the same time, we've got to drastically reduce costs, and perhaps the new standard is a Medicare break-even. And we've got to do this in the context of using analytics to compete and monitor performance. The second strategy is to understand your data and how it fits together. We have significant investments in legacy platforms. Much of our data are in silos, and we need to see the relationships and interrelationships among and between the data. And we also have to have our vendors and partners work together. So one frame on this is how do we take our proprietary data, which is hospital or system-centric, and then how do we take publicly available data, which is oftentimes at the federal, state, and local level, to create an integrated data source. So in fact, we can look in an organized way internally what's going on within the hospital system or within the hospital, and also how can we look at what's going on externally in the marketplace. The third strategy is to understand your performance compared to others, and we suggest using a hospital strength index, which is comprised of 50+ metrics rolled into 8 indicators in 3 categories for 4,600 hospitals in the United States. And the 3 categories are market strength, value-based strength, and then financial strength. And this gives everyone a way of measuring your effectiveness in a new healthcare environment, and target to board members and CEOs across the United States. That can be a very effective board and management scorecard, because we know that 90% of off-quality expenses and revenue losses generated by 6% of your physicians, and 90% of your quality issues are focused on a handful of improvements. And we define the cost of off-quality expenses when we compare your physicians to the 65th percentile of a peer group based on evidence-based medicine. Strategy number 5 is to identify ways to improve the market dynamics, and there are 2 steps here. First is an environmental and market assessment, where the market assessment includes an overview of the service area. More often than not, includes a primary and secondary service area definition, as well as a target service area. And more organizations and healthcare organizations are defining their ACO service area. In addition, we look at service area demographics, a competitive analysis, medical staff analysis, as well as hospital utilization and market share. The second step is to use GIS mapping to see the interrelationships displayed on a map. So we look at things like the ACO and Medicare beneficiary files, the hospital strength index. We look at high volume, low performing physicians, demographics, as well as population-based planning. And then the sixth strategy is to understand the relationship between internal performance and market dynamics. So you basically look at the internal market, internal perspective as well as the external perspective in an integrated way. And now LeeAnne's going to demonstrate how we actually do that.
Thank you, Scott. Welcome, everybody. I get the fun part of this presentation. I actually get to display all this information on the map. So just a little quick overview here of GIS technologies. About 4 years ago, we took a lot of our planning information and began to load it into the map. So your traditional market share information and all of that. So I'm going to talk through very briefly about what GIS technologies are and how we're utilizing them. And then I have 3 scenarios today to discuss. These are real-life scenarios from our clients that we're currently working on. We thought we'd share these with you. So just very quickly here about GIS technologies. One of the great things about this is taking all of that information that I'm sure you have floating around in your organization and begin to lay it into the map somewhere so that we can begin to interact with this information. And there we go. Okay, so we can lay out everything from hospital systems to various hospitals. We can lay in chest pain centers. So a lot of that information that you're going to need during your planning cycle, we can be able to put into the map and begin to interact with it. So I'm going to click into one of these. So the great part about GIS is you're able to see a lot of this detailed information. So here's a hospital in the Jacksonville market. We know what system they're from. And then in addition to that, we can pull information and begin to incorporate other information like report data, or we can put links out there so we can go to their website, or we can pull up their value-based purchasing calculator score. So think of this platform as you think of your own information and using GIS technologies, how you can take a lot of this information and begin to formulate a strategy from it. So we have an awful lot of content here that we can use. We can look at nursing homes. So for those of you looking at the post-acute care environment in your market areas, this is a great way to start organizing your market and being able to look at what we have in terms of the nursing home information. In this case, we happen to be pulling in the nursing home cost report. You could do that on LTACs, you could do that on hospice, you could do that on home health. So as many of you are beginning to look at how your providers are interacting with each other, this is a great way to pull that information in and begin to show it on the map and have the location of all that. Some other things that we can show on the map here besides the traditional market share or service area, CMS last year released a Medicare ACO spend file. And we have found this file to be very useful in looking at these markets, and it's at a zip code level. And once again, this great thing about GIS is being able to drill into this information and see more information. So in this particular zip code here in Jacksonville, we have about Medicare spend of about $41 million. They break it by inpatient at $21 million, outpatients $5 million, and physician totals $15 million. And for those of us in the data world, we haven't seen a lot of physician detailed information, so it's great to see this file. And the other part about this file that's really pretty unusual is that they also released within the inpatient, you have the 25 MDC levels, and outpatient, you have it by ambulatory patient grouping, and physician is based upon the CMS defined physician grouping. So this is a great file to be using as you think about your planning scenarios in your market area. So you're kind of getting the gist of how we use GIS technologies. Again, it's all this information coming to the map so that you can begin to take that detailed information and interact with it. So I'm going to talk about a couple of scenarios here, and these, like I said, these are real-life scenarios that we are currently working with. And I'm going to start off with a scenario. I'm calling it the downstream effect. And so this is in the Jacksonville market, and this is using our hospital strength index information so we can get this on the map. And so the way the hospital strength index, as Scott had described, is an overall score, but we can also break it into some component parts. So here, these green hospitals here in the market are top performing hospitals. The yellow hospital is the second tier down, and the red hospitals are the third tier, and we don't have any gray ones on the screen here, but that would be the bottom quartile. So on all of those 8 pillars that are out there on the Hospital Strength Index, this is the overall composite score. So what's interesting about this is that I can take things like my ACO member data. So for those of you on the call who are now a Pioneer ACO, we can begin to lay that information in as well. So now we have the kind of the latitude and longitude of all the members of my ACO. Now this is a made-up example, but it's very easily to be a real-life example. So let's assume here we've got about 2,000 members right here in this little market area. And my hospital is a yellow hospital, so I'm a pretty strong performing. And upstream here, I've got 2 green hospitals, so I know that they're pretty good hospitals as well. So the other thing I want to look at now is when I go back to the Hospital Strength Index, I can begin to look at maybe their outcomes. So if I'm managing this population, it's going to start to become important to me to know what my competitors are doing or other hospitals and providers around me in the marketplace. So here on the outcome side, this would be your AHRQ, patient safety indicators, and adverse events, and also mortality. So my 2 hospitals upstream right here from my patient base are performing pretty well, and so am I. When this gets interesting, however, is that when we lay in the quality index. So now, here's my patient population here for my ACO, but upstream I have a hospital that's in the 3rd quartile of all hospitals in the United States. So it's not real great on quality, probably could use a lot of improvement. I'm doing very well in my sample scenario, but my hospital upstream that is very close to my patient population, maybe not so strong in quality. And that's going to be a concern as I look at my ACO population, because my ACO population could go to this hospital. And so the last indicator I want to look at here real quick are patient perspectives, or HCAHPS scores. This is whether or not the patient would definitely recommend. So if we recall, we had a quality hospital, a poor quality hospital up here, or not so great in quality. And on top of that, to compound my problem with my ACO population, I'm a poor performer in patient perspectives. So patients don't really like my hospital really all that much. But on top of that, I'm kind of playing downstream from somebody else's quality. So these are things to think about as you look at your ACO population. Now I'm going to layer in my market share information here, and we'll bring that up on the map. So here's my population here with my 2,000 people that I'm concerned about, and let's say we're going to click into this market share layer. So in that particular zip code, there are about 4,900 inpatient cases, and I'm picking up about 1/3 of those. But that also means 2/3 of my patient base here in my ACO population may be migrating to other facilities, and their quality may not be as great. Now, I know this is an ACO kind of an example, but here's the reality. You need to be looking at all the other providers in your market to understand their quality and their performance, because you may become the downstream effect of somebody else's poor performance. So you need to start thinking about your communication strategies and how you're going to strategically keep those patients at your high-quality hospital and maybe out of the reach of the other hospitals in the area whose quality may not be as good. So it's a great example of, taking a lot of this information in a very short amount of time and begin to layer it in. Okay, so for my second example here, I have a physician example, and this is one of those aha moments that I had a couple of weeks ago. In our systems that we have at iVantage, we have a clinical scorecard for physicians, and we're able to put up a composite score on all physicians on a medical staff, and that basically looks at average length of stay, readmission rates, mortality, things like that. And so what I was looking at one point in time with a client was to see where are my poor performing or kind of my bottom-tiered physicians located, so I know where they are in relation to the rest of my patient population. In addition to that, I can layer in the 3-star physicians, and these would be my top performers, the green stars here up on the map. So of course my mind went to, okay, so where are my high-volume, low-performing physicians in this marketplace? And so I put them up on the map, and I started looking around. Now, this is a real example here. The data is made up in this market, but this This is a true-to-life example. So I'm able to pull up the scorecard on this particular physician, and this would be considered a physician that probably needs some work. So in this case, this physician had 154 patients with an average length of stay of 6. Cost per case is not so great, about $9,200 per case. Mortality is not bad. It's pretty low. Readmissions are not great at about 15%. Cost of quality is not bad, but margin and profitability is not so great. So it'd be really easy to go and say, hey, this physician's not performing very well, and have a conversation with them. But this is where it got interesting. I'm able to, in our system here, begin to search by physician. And what we're able to do is put that physician's cases up here on the map. So in this case now, I can see all this physician's cases. So this is where it gets interesting. So I had a physician that's probably not a great performer here, but I'm now able to switch views and look at the patient population of this particular physician. So this gives me a quick synopsis. This physician was labeled on the credentialing system as an internal med physician, but in reality this physician is a hospitalist. So as I look at the mix of patients, they do kind of the general stuff, general medicine, cardiac services, probably some general heart type work. And then looking at the financial class information, this is predominantly a Medicare population, some managed care. But this is my aha moment. If I look at the emergency room patients, 90% of those patients of this physician are coming through the emergency department. So it changes my perspective on how this physician is performing. Maybe there's some things that physician needs to work on, but this probably is more of a population-based planning problem than it is a real, a quality problem with this physician. So I need to change my attention back into the marketplace and try to figure out how we're going to manage the patient population better. This will play later into transparency. There's been a big call for transparency on the physician side. So making sure from a hospital perspective that you're helping out your physicians is going to be very important. I thought this was a really great example of kind of the new healthcare reality and how data begins to fit together. So for the clinical folks on the call, you're going to have to get to know the strategy folks. And for the strategy folks, you're going to have to get to know your clinical folks really well, because now these two pieces are beginning to drive strategy in a market. Okay, so for my third example here today, I'm going to go back here to my dashboard. This is on bundled payments. I had this question recently about how do I go about figuring out whether or not I'm ready to do a bundled payment scenario. So first thing I would probably be looking for is some of my traditional market information. I'm going to switch product lines. I'm going to focus on orthopedics. So here I'm looking at my market cases here in this market, and I can see that they are growing. So that's probably a good thing to be looking at. The second thing I'm going to be looking at is probably looking at my position in the marketplace. Am I the leader in this, or am I going to try to do a disruptive strategy of some sort? And maybe I'm in third place in the market, and this is my strategy to disrupt what's going on in the market to go after bundled payments. So once I've kind of decided to go forward, the next thing that I need to do is I need to start looking at my internal performance. So here I am on our benchmarking site. This is my hospital here on orthopedics. I'm running about $10,000 a case, and I'm high compared to all the other hospitals in my comparison group. So that's important for me to know. I'm going to have to do some work in order to get this process underway. I can also look at the excess here. So this is probably more of a conservative excess, more of a traditional under current payment terms. And we can see where we have some areas that we need some work. So if I'm thinking about an orthopedic bundle payment here, I've got knee and hip replacements here at about $1.5 million in excess. But what if these rates collapse towards Medicare break-even? Then what happens? Well, then I'm beginning to see that I have a lot more work to do. I'm looking at about $3 million in excess that is going to have to be addressed within my organization. On top of that, in my knee replacement category here, a lot of these patients are severity level 1 under an APRD or G grouper. that means it's a pretty homogeneous population that I can probably work with my physicians to change. Now there's a whole other can of corn with the politics of being able to get this done, but at least now I know where I need to focus some of my attention. So if I drill in one more and take a look at my knee replacements here, I can actually go to my physician XF. So now I'm looking at my physicians that maybe or may not be ready for bundled payments. So this physician right here is still running at an excess of about $369,000 compared to other ones. So this is a great way to step through your readiness to tackle bundled payments. So on that note, I'm going to go ahead and turn this back over to Scott Goodspeed, and he's going to wrap us up.
I'm going to go on and talk about strategy number 7. Because as I mentioned, I was in a meeting with a group of board members and a CEO in a healthcare system in the state of New York about 2 weeks ago, and the system board vice chair said, you know, competing on analytics is incredibly important, but is our organization ready to do that? And I just want to share with you, there are 3 cultural styles that we find in hospitals and healthcare systems. And the first style is what I call a constructive style. The second is a passive defensive style. And the third style is an aggressive defensive style. And there's a methodology and way of measuring which style is characteristic of your organization. But the research that we've been doing and what we know given the 3 cultural styles is a constructive culture leads to better execution of strategy, improved quality, engagement, retention, positive financial results, but it also is the style that is most effective using analytics. This is what the measurement tool looks like, and where you see the constructive style in the blue, this actually is 8 organizations where they looked at the impact of the most effective and successful leaders that were using analytics. So culture does make a difference. The other thing that we'd like to offer is anyone on the call who wants a copy of their hospital strength index, or if you're part of a system, we can give you a roll-up of the index score. But we also would be more than happy to provide a copy of your value-based purchasing incentive. And you can send me an email, and we'd be happy to send that to you in the next couple of days. So with that, we'd be happy to take questions.
Hi, thank you for a very informative and enjoyable presentation. I just want to remind everybody that you can submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking Send. Our presenters will attempt to answer as many questions as they can in the time we have for Q&A, and will follow up on all questions they do not have the opportunity to address. Right now, I'm going to ask this first question. This looks like a lot of data and a lot of work. What does it take to put this information together?
Thanks, Kathy. This is LeeAnne. Yes, well, my first advice to the folks on the call is to take a look at a lot of the information in your organization, and especially on the market side, begin to inventory what you have. You know, from being a planner for a long time, we get, you know, spreadsheets, Word documents with information on it. But, you know, I think it's gone down to another level of detail. So I would highly recommend start in your own organization, whether you have a GIS system or not. Begin to organize your own data. Where are all your assisted living facilities? Where are your nursing homes? And begin to look at all of that information and have some idea of where it's coming from and its cleanliness as part of having to clean up a lot of this information. So it is a lot of data, but a great place to start is by just a basic inventory of what you have and where you can get it and how frequently is it. I think that's a great place to start.
Okay, thank you. This next question, given the 7 strategies, where should we begin?
Hi, this is Scott. I would begin with strategy number 2 in terms of understanding your data and how it fits together. And there are kind of 2 perspectives here. One is you have your own proprietary data, which is hospital or system centric, and we also have publicly available data, and that's the basis for things like the Hospital Strength Index and your value-based purchasing incentive score, and take both of those data sources, create an integrated data source, so in fact you have a internal perspective on the organization related to clinical and functional benchmarking, as well as a external perspective on what's going on in the marketplace. That gives you, so to speak, one-stop shopping in terms of access to the data, but you can look at that data in an integrated way. And one of the things I said during the presentation in terms of strategy number 2, that a lot of data are in silos, and we need to see the interrelationships between the data, and by bringing the publicly available and proprietary data into an integrated data source, you can see the interrelationships between and among the data.
Great, thank you very much. This next question, how does this work for a hospital system?
This is a great way on a hospital system to be using this information, especially if you're, a regional player or a national chain. Being able to organize a lot of this information. We're using some really interesting techniques in a hospital system, especially if you're a national chain, to do distance decay models, mostly because not all markets are created equal. So how do you line up a Los Angeles versus a Miami and understand the competitive nature in there, and how do you begin to allocate capital based upon that? So we've got some really great examples that we're working on with hospital systems. So this is a great way to visualize a lot of things that are going on, both at a rolled up overall company perspective and then also down to a detailed level within the local market.
Great, thanks so much. Another question we have here is, what is the best way to measure a hospital or system's performance, and is comparative data available?
Hi, this is Scott. I would use my suggestion is you use the Hospital Strength Index. The Hospital Strength Index uses only empirical data from about 50+ metrics from 3 perspectives, and we look at that from a marketplace perspective, a value-based perspective, and a financial perspective. And because there are 46 hospitals in that study group, all of that empirical data is available for just about every hospital in the United States. So you can look at that as it relates to a hospital or a healthcare system. You can compare yourself at a national, at a state, or even a regional level.
Okay, great, thanks. This next question, is there a nursing scorecard similar to the physician scorecard?
No, not yet, but as more data are becoming available in the marketplace, I see lots of room for doing different types of scorecards. So right now it's mostly on the physician side because that's typically what's on the record, but I think as more data becomes available, absolutely there's room for other ways to measure performance. So in addition to that, in terms of some of the other scorecards, like our Hospital Strength Index, we are looking at other post-acute providers on a scorecarding system. So again, as you entered into bundled payments, where are my hospice and home health agencies in relation to their performance, so I know which one to choose. So we are looking at a lot of that and beginning to think about that and work towards that.
Great, thank you. Another question for you, LeeAnne, is how recent is the data, for example, the ESRI?
For the most part, we're pulling data as soon as it becomes available. So the ESRI data now is 2011, 2016 information, and I believe that they're about ready to release their 2012, 2017 information. The CMS data, it just came out. The MedPAR file is 2011. So it's going to also vary by, what source that we are currently using.
Okay, perfect. Thank you. Does iVantage have the Hospital Strength Index for hospitals in other states such as New Jersey?
Yeah, absolutely. We scorecarded, we built the hospital strength index on 4,700 hospitals, mostly because we hadn't seen any rating systems out there that included all hospitals in the United States. What was excluded were specialty hospitals, and that's pretty much it. There are a couple of critical access hospitals we didn't have enough data, but I will tell you from the data standpoint, we worked very hard to keep every hospital in on the indicators, including critical access. We were the first company to go ahead and score the critical access hospitals on on these measurements so that they would have some idea of where they stood in the marketplace as well.
Okay, thanks again. Is this product only used by hospitals, or is it also used by other sectors of the market?
Well, being a GIS planner, I think it should be used everywhere. You know, we use it in our we use mapping in our daily lives, whether it's Garmin or TomTom or MapQuest or any of those products. So I see GIS applications regardless of the sector of the industry that you're in. It's widely used in environmental, it's widely used in retail, and I think full adoption by the healthcare industry would be a great thing.
Okay, can we build our own analysis models and leverage the spend analysis system to populate them with relevant data?
We're beginning to go in that direction. I mentioned the distance decay modeling system and being able to put that information together. So yes, we are moving in that direction. As of today, it's mostly, you know, on-off switches and loading the data there, but we're putting in some techniques so users have the flexibility to begin to model out their own scenarios and also add all of their own data.
Okay, thank you. Here's another question. Where do you find the market outpatient data? In Maine, it's very limited. Maybe with the Maine for Net, it will get better?
Wow, outpatient is always a tough one, and it's going to vary by, you know, your locale. And states have done, I think, a pretty good job recently of trying to build and release outpatient data. You often hear clients talk about how poor the quality is. So the thing about outpatient is, first off, you have to know what you're doing with it. You have to understand what is included and what is excluded. Are the imaging procedures included in the data set or not? So my first advice on that one, first off, read the documentation that they send you. As far as rollout of full outpatient, again, it's going to vary by state. CMS has released outpatient down to the claim level. And I think the other pitfall that a lot of folks run into with outpatient is trying to figure out how to product line it. There are certainly many techniques out there to be able to product line and get an apples-to-apples comparison with your inpatient cases.
How often is the data updated? Is there an additional cost?
Or updated, and it's going to vary by the data set. Some of it's every 30 days. We're working on some sandbox technology to allow you to update whatever you want when you want to, and that will be available this fall. So it's going to vary. It depends on the layers that you're licensing, and you know, obviously demographic pretty much comes out once a year, but market share is going to vary by state. CMS will be out once a year. But things like NTI, the physician layers, where we've got physician office locations, that often updates every 30 days. Cost reports are every quarter. So it's just going to vary depending on what it is that you're trying to do.
Okay, perfect. If spending is mapped by an automated tool, who performs Q&A on the automation to ensure that mistakes are corrected?
Oh, at iVantage, we spend hours cleaning up data that we receive, looking at anomalies in the data, you know, making sure that it is as accurate as it can possibly be. So we have analysts here at iVantage that have 30 to 40 years of experience of looking at data in order to try to make sure that it is as accurate as it can possibly be.
Okay, thanks. Again, I want to remind attendees to enter a question for staff in the space provided and click send, and we'll try to get to as many of those questions as possible. We're going to take another question here, just a moment. Hold on just one moment while we're reviewing. All the questions are coming in so fast. Okay, this next question, where critical access hospitals are not required to submit many of the quality and HCA-HPS data sets, how important do you feel it is for critical access hospitals to be aware of their scores and impact on their hospital strength index scores?
That's a great question, and it's HCAP scores. So absolutely, I think being aware of where you stand in the marketplace, where you stand in relation to your other providers, it is becoming more and more important for you to collect the right information, submit it, and understand where you stand in relation to others. Awful lot of M&A activity going on out there, so whether you're looking to be acquired or somebody else is, or you're looking to partner with somebody else, you need to not only know your score, but you probably need to know your competitor's score or other providers in the area.
Hi, this is Scott. Of the 800 hospitals that we work with about 200 critical access hospitals, and as I travel across the United States, I'm hearing more CEOs and board members making HCAPs a requirement within the organization, even though federally it's not a requirement. So we're seeing more and more critical access hospitals getting into HCAPs, and they're also beginning to request their value-based purchasing incentive score. So I think you're going to see more and more critical access hospitals get involved with HCAPs.
Thank you, Scott. This next question is the data just Medicare data? For states that require all admission data, do you include that also?
Yes, wherever we can, and it's publicly available, states such as Florida, California, Texas, we can easily purchase that. In other states where it's privately held, Louisiana, Kentucky, states such as that, we work directly with the client in order to help them get the best cut of data that they possibly can. But those can easily be layered onto the map. On the map that I showed you today, where I layered in market share, that was the Florida Hospital Association data, the Florida state data. So yes, absolutely, all those layers can be included in great detail.
Okay, thank you very much. What is the best, I think I've asked this question already. How do we better understand our organization's culture?
This is Scott. One of the things that we've been doing over the last 2 years is working with hospitals and healthcare systems across the United States, not only development of a strategic plan using these analytics, but the question comes in, how do we begin to embed the strategy within the organization, and how do we compete using analytics? We use a tool working with human synergistics, and so we will come in and offer the organization a measurement and a way of surveying key groups, which will identify their type of organization culture. And again, in our experience over the last 2 to 3 years, we find that those organizations that have a constructive style are more likely to compete using analytics. But if you also look at the relationship between financial performance, market share, and other indicators, there's a greater relationship with a constructive style than the other two that I had talked about.
Okay, thank you. I want to direct everyone's attention to the last slide that you see up on your screen. If you want to contact Scott directly, his phone number, email address is on that last screen. Additionally, I want to thank everyone for attending today's webinar. We look forward to having you join us again for future webinars, and that will conclude today's program. Thanks for attending. Have a wonderful afternoon. Bye-bye.